Endotalks podcast, a podcast about the latest research on endometriosis.
Thank you for being with us for this new episode of our podcast. So you're Mathew Leonardi, and maybe you can introduce finally yourself for our listenership.
Absolutely. It's a pleasure to be with you, Yohann, and to be part of the Endotalks podcast. Really exciting new endeavor that you guys are doing to share knowledge about endometriosis with patients and with healthcare providers around the world through a free access, opportunity. I'm grateful to be here from Canada right now. I'm in Hamilton, Canada at McMaster University, and I am a surgeon sonologist. I'm a gynecologist focusing my efforts in endometriosis, the clinical management, the sonographic assessment, the surgical management, the whole scope of care for endometriosis patients. I do care for other patients as well with other gynecologic problems, but endometriosis is the primary one. And I'm, as I said, a surgeon sonologist. I scan, which is a bit unusual for a North American, but maybe not in the future as we train more and more people to know this approach to endometriosis. And finally, I do a lot of research in endometriosis. So I'm an academic. I've done my PhD many years ago now and have a large research program focusing my efforts on the entire spectrum of endometriosis, from diagnosis all the way through to therapies and everything in between, complementary and alternative options, patient experience, the psychology of endometriosis. It's a really fascinating program, and I'm really happy to be part of this world because it's something that we need to make big improvement strides on to help our patients.
Limitation that is associated with ultrasound is obviously the missing diagnosis for a patient with superficial endometriosis. Can you maybe tell us, since you performed a lot of review on the performance of this exam, what are the latest performance reported for diagnosing superficial endometriosis?
Yeah, it's a good question. It was forever the who would never see on ultrasound. I was taught that when I first entered the world of endometriosis and endometriosis ultrasound. But slowly, the combination of ultrasound and surgery for me, when I was in Sydney, helped me realize that it was possible to see it. So as part of my PhD with Prof. Conductor, we did a diagnostic test accuracy study showing that we had a very high sensitivity, about close to 80%, and even higher specificity, almost 100%, for superficial endometriosis when there's fluid in the pelvis. So sometimes people have fluid in their pelvis, and this can be from menstruation, ovulation, and that fluid helps see very, very small things that are lining the surface of the peritoneum, the abdominal cavity coverings. And in the absence of fluid, it's not really possible to see superficial endometriosis as easily. There are some instances where you can have suspicion for it, but if there's no fluid there, it's almost impossible. And since then, we have been routinely looking for superficial endometriosis, but only in those who we don't find deep or ovarian.
Obviously.
Right? It doesn't make sense. You already know that there's deep endo, ovarian endo, adhesions. Superficial endo is not going to change the clinical management or surgical management at that point. So we don't go crazy looking for it. And we have very high accuracies, but we cannot rule it out. That's the key.
That's the problem, basically, because especially in patients from maybe 15, 16 to 22, 23, who most of the time have early disease or solely superficial phenotype of the disease, that the patients that are the most probably suffering from the delay prior diagnostic.
Yeah. In the 2010 era, I think it was roughly, the idea of the clinical diagnosis really took effect. So instead of being uncertain, telling people we don't know what's going on, essentially what was the new standard was, if you believe somebody has endometriosis based on their symptoms, you tell them that they have endometriosis based on their symptoms. And so this is something that we still have to consider doing, because I'm not sure it's viable to be operating on everyone that comes in with pelvic pain, possible superficial endometriosis. It's a lot of people. And we also understand the controversies around the therapeutic effect of surgery when endometriosis is identified. I mean, I'm a surgeon. I do surgery on endometriosis all the time. I do think it's beneficial, but there's nuance and context there. The scan has a power that people are not yet aware of, which is the concept of helping create a narrative for patients about what's happening and what's not happening in their pelvis. So we all know that our nervous system, our pain system, is ready to protect us from pain events. So if we touch a hot stove, we don't even think about it. Our arm retracts, our muscles take effect, and there is an intention within our body to protect ourselves without any active thinking. The muscles of the pelvic floor, the muscles of the lower abdomen, the lower back, similarly respond to danger signals. So if there is inflammation present from endometriosis or some other source, the muscles go into a state of tension and they try to protect us. And this is a normal response, but we have to kind of help people understand when there's danger, real danger, and when there's not real danger. And endo is terrible. We know that. People say, it's called a benign disease, but it's anything but benign. It destroys people's lives. But really, truly, it's not cancer. It's not going to kill somebody. And in the context of ruling out deep endo, ovarian endo, severe adhesions that are architecturally changing the pelvic anatomy, the superficial endometriosis shouldn't be as feared. It's still important for us to acknowledge and take care of, but it shouldn't be as feared. So we try really hard to implement concepts of pain safety through ultrasound mapping of endo and also ruling out bad endo. We tell people your pelvic organs are in good shape. Your uterus, your ovaries, your bowel bladder, ureters, ligaments are all safe. And there's no evidence of any adhesions. This has lots of good prognostication from a fertility standpoint as well. We can provide people with concepts of pain safety so that they are not going to let that nervous system or pain system be kind of at that high level of responsiveness all the time. But also at the same time, we're going to help people treat their pain. So it's a bit both. We got to treat the pain. We got to acknowledge the pain, but we also have to let the nervous system know, hey, we don't need to be in that level of pain protection, because what's happening right now is not as dangerous as maybe what the brain is thinking it is. You know what I mean?
Yeah, that's a very interesting concept. But I think one of the difficulty for all the physicians that meet on a frequent basis with patients with endometriosis is that first patient wants to know, and it's hard for patient to accept, even if you tell them about the pain safety or whatever you call it, but they want to know, and they can't understand why for so many diseases you can basically click your fingers and have a diagnostic, and for endometriosis, you can't tell them for sure if they have or if they are not. You can tell, well, you're not in danger, but at the same time, they don't know for sure. I think that's very hard for the physicians to deal with this as a physician and as a human being, because you cannot provide with a definite answer for your patients. And the second point is that once you even evoke the diagnostic in these patients, you raise many questions, because for sure they're going to go on internet, on social media, and they're gonna read that they can be infertile and all kind of things that can be, I think, much more deleterious than the disease itself sometimes. And now that we can do oocyte preservation, and it's hard to I think advise patients when you can't give them a definite diagnostic, and even if you can say that, okay, they have no severe disease, no digestive involvement or anything, but it's hard. I mean, in the relationship with the patient.
Yeah, it's so hard. I live and breathe this every day. And some patients are very happy to know that they're in a safe place and that they probably have what we call superficial endo. I explain to them, the size, the potential for this disease more in a visual, tangible way so that they can understand it. But some people are not okay with that. They need to know. And I feel that, because I don't know if I would be able to exist so effectively with this chronic pain problem and a mystery of, is there endo there or not? And I know that I maybe don't align my thoughts with a lot of people who really truly believe in the excuse me, in the clinical diagnosis. There are lots of people who don't even really think you need the ultrasound to identify deep endo, because they're just going to treat everyone the same anyway with hormonal medications. Obviously, I think that that's very wrong. But the superficial endo, I'm not sure yet. So a few years ago, we wrote an article with one of the other former fellows in Sydney and Prof. Condis on maybe there is a role for laparoscopy in these patients. Maybe there is a therapeutic value to know, not to necessarily even treat, but to know that endo is there and give people kind of closure on that. I have to say, I don't readily offer diagnostic laparoscopy for the purposes of to know. It's used in my patients who are good surgical candidates for excision of endometriosis when the imaging is negative. But there are some people who, in our opinion, based on science, are not good surgical candidates. And you know that you can go in and take out all of the endo there, and 1 month later, they're going to be the exact same because they have a number of other issues. They have pelvic floor issues, they have bladder issues, they have PCO.
Sure.
There's all these other things that are playing large roles. So the surgery is not going to be helpful for those people. But that's also kind of controversial and it makes people upset because they think, I just need to know and I want you to go take it out and I want to be pain-free. So it requires a very strong therapeutic relationship to develop with these patients. And it requires repetitive visits, follow-up visits to do education, to inform people, to make sure that they know you're there for them, you're going to help them. You're not just going to abandon them because the imaging is normal. Lots of people have had that happen to them. So it is possible to overcome some of those issues with a good therapeutic approach.
Okay, good answer. I think that's a very important for when you treat patient with endometriosis. The relationship you have with the patient is determinant.
Mm-hmm.
Even I think the response to the therapeutic you're going to give your patients. And so how often, as a sonologist, do you prescribe MRI to patients following your ultrasound examination?
Almost never. Really, almost never. I think the only times that I will order an MRI is if the pathology, the anatomy is so bad, so distorted, and I have a question of whether there's a bowel endo nodule that I just can't be certain about. Often there are higher lesions that are pulled in between the big ovarian endometriomas, and I just need to know with another imaging modality whether my suspicion is correct or not. So that's probably 1 in, 100 cases that happens. I don't order MRI in those who have normal ultrasounds because MRI is not going to be helpful for finding a 1 millimeter superficial endometriosis deposit. There's no way, not yet anyway. So yeah, almost never.
So in another perspective, how do you feel comfortable with, and do you perform physical examination for the diagnostic of endometriosis if you already perform the ultrasound, or do you systematically perform the physical examination prior doing the ultrasound?
I've sort of gone back and forth on this. When I was first arrived back in Canada, I didn't really feel that a physical exam for evaluating endometriosis was that valuable because the imaging is so accurate for uterosacral nodules, bowel endo, and I think most of these lesions are high that you can't feel them anyway with your fingers. So I didn't do it. And then slowly I started to do the exam again, but not for feeling endo. I really started to understand the pelvic floor more. So we do more of a myofascial pelvic assessment versus using my fingers to feel a nodule. And so we do routinely do a physical exam for the purposes of understanding the pelvic floor, but not to feel endo. Not at all. Speculum sometimes to visualize vaginal endometriosis. But again, most of that is diagnosed on the imaging already. So it's more, to see the size of it visually. But it doesn't add that much value from a clinical surgical planning standpoint.
And so you're also comfortable planning surgery with no examining patients, or do you examine patients just prior the surgical gesture?
Again, like we have the full map of everything that's happening with the endo state using the imaging. There's a necessity from an exam standpoint. If you're planning, for example, a concurrent hysterectomy, you want to look at the patient's abdomen. You want to make sure that, like classic exam stations, you look for scars, previous scars, you look for masses. You don't want to end up finding, they have a umbilical endometriosis when you arrive at the operating room. So there's utility from a visual standpoint there. But honestly, the ultrasound gives us everything we need to plan surgery really, really effectively. That the exam does not guide us any way really for doing the good surgery. It mostly helps us understand the concurrent pathologies, abdominal wall trigger points, pelvic floor, myofascial tenderness. These are the concurrent problems people face that will eventually confound your surgical outcomes. So if you don't know these things before surgery, you just go do surgery for endo and you think, oh, they're going to be great. And then they come back, they still have their myofascial pain triggers because they haven't gone to see physio and start to address those. Well, they're not going to feel better overall after surgery. So then you're going to not have done a good job.
Yeah, sure. I think that the main issue is how to select patients to go through surgery, and how often you have to not consult patients towards surgery, even if they are resisting medical therapy, because surgery might not be the answer for these cases sometimes. And that's hard.
For sure.
In case it was not recorded initially, how do you respond to the critics that the ultrasound is a dynamic exam, and it cannot be interpreted in another center? For example, if especially in Canada, where you have a very large country, and I think patient cannot always live around the sonographist specialist. So how do you comfortable with that, and how do you manage patients that are not living in your neighborhood or something like this?
Yeah. In Canada, there is probably a higher degree of acceptance that people will have to travel for specialty type care because we have such a large geographic country. So I do see people who fly to visit me for appointments from within my own province, not out of my own province, but within my own province. People have to fly to come see me because Ontario is bigger than some European countries. So, definitely that's something people accept as it's not ideal. If there was somebody close to home, that would be much better, but it's just not that case. So I do have people traveling to come and see me for both the clinical management pathway, which includes obviously imaging, but also, for example, I have a strong relationship with people in this city called Thunder Bay, and it's about a 1.5 2 hour flight. And so people will fly to come and have an ultrasound with me, and then they use that information to decide, can they have surgery in Thunder Bay, or do they need to come to Hamilton for their surgical management? So it's a very strong triaging tool in that instance. But as you said, it's hard to interpret ultrasound done elsewhere or by other teams. The reason why this is the case, at least in a North American setting, is the culture of taking videos has not been really instituted. The world of ultrasound is really picture, and you cannot do an endometriosis ultrasound with just picture. It has to be dynamic, and you actually have to record the dynamic nature of this ultrasound. So when I teach my sonographers, who are, again, not physicians, they're for all intents and purposes a technician. They know how to take all the pictures. They know and the videos. They know how to perform sliding sign, triangle sign. They know how to assess ovarian mobility. They know how to, in the posterior compartment, push and pull so that the fluid fills that space. They know how to capture those, so I can interpret them after the fact. And actually, in the majority of those cases, they do a great job. And I have everything I need to provide a very good report, even if I don't go in the room. So you can teach people how to do this. It's about a protocol. It's about teaching the skills and implementing a systematic protocol. So that is possible. And maybe one day what we'll see is we can teach sonographers around large countries to be able to do these scans, but they're interpreted in a more specialized center by a team such as myself and my colleagues. So that way patients don't have to travel so far to see us. And then probably there will still be a small proportion of those that do require the scan by us because it's so complex or there's missing pieces on the original scan done by the sonographer. But if it's a minority, then that's okay. That's less than what people are currently doing from a travel standpoint.
Okay. But how effective do you think it is to train like gynecologists doing sonography as at the same time they have to learn how to treat patients, do complex surgeries? I mean, how do you plan this education for during their residency or maybe fellowship? Because performing complex surgery for endometriosis is already taking a lot of involvement in their education for those who want to do this at complex levels. So how do you think it's going to affect their training, or how can you integrate this in the training of the new generation?
I have plans and ideas to do this. So I think the concept of fellowships in minimally invasive surgery and endometriosis surgery are a little bit more common in the North American setting than in a lot of European countries. Essentially, in Europe, you guys know how to scan through your training. So you have very good foundational skills, probably not endometriosis skills per se, but foundational ultrasound skills, how to find the uterus, how to find the ovaries, how to characterize anatomical pathologies in those particular structures. So it's probably within reason that in your own residency programs in a European setting or in other countries or continents where ultrasound is done in residency, for you to push that envelope a little bit further and to start to look for endo. And maybe that will allow for the general OBGYN who goes out into communities around the countries to be able to start screening, looking for a negative sliding sign at the beginning, simpler things. And then those who focus more on endometriosis and minimally invasive surgery in Europe, they should have integrated into their fellowships ultrasound for endometriosis. This is what we do in North America. So in North America, well, I can't say all of North America because actually it's still very, very uncommon. And we're one of the only centers that's really integrated this in a very formal way. But essentially, we don't get any foundational learning in our residency for gynecology ultrasound. We know almost nothing. But if you become a fellow in minimally invasive surgery after 5 years of residency training, you already have a very strong knowledge of anatomy, of pathology. You already have good surgical skills. But now it's about developing those mastery of surgical skills for endometriosis and other complex gynecologic pathologies. So integrating it into the fellowship in the clinic where you're seeing the patients and then you're operating on those same patients builds a very, very effective learning, closed loop communication. You know the patient, you know their symptoms, you do the scan, you do the surgery, you close the loop. You understand how the disease exists in both the clinical, sonographic, and actually surgical way. So it really kind of solidifies the knowledge. And so I can tell you my fellows that have graduated in the past 4 years since I've been back in Canada, they all have gone off and have complete confidence and competence to do advanced endometriosis ultrasound and also all the ancillary things, looking at ovarian masses, adenomyosis through MUSA features. They are exceptional. They are sonologists. So they are surgeon sonologists. And now individually, they are in different centers and they are teaching people in their centers how to also scan. But I think it has to be in the fellowship setting in the North America education model right now until we get more generalists doing ultrasound through their residency.
Okay, very clear. Very clear. And in the operating room, how often do you use the ultrasound during surgery? I mean, do you perform ultrasound to make sure you removed all disease, or do you perform in some specific disease location, or never? Maybe, I don't know.
Sometimes it's a sometimes thing. So I would say we scan every single patient as soon as they're asleep again. So that way we have an instant visualization of where everything is, even though we have our report and our previous pictures as a learning tool for all of the people in the operating room, the fellows, the medical students. Again, knowing this is what it looks like on ultrasound, this is what it looks like on surgery, helps close that learning curve. So we do scan everybody there, but it's not for a unique need like, oh, we have to figure out which type of bowel surgery we're doing today. We already know all that from the office. And then intraoperatively, there's the rare instance. This is more for the typical pelvic endometriosis scenario, rare instance that we thought that there was a bowel nodule preoperatively. Once the anatomy is normalized, we take everything down. We think, where's that bowel nodule? We can't find it. Then we might pull the probe out and scan them again to localize that nodule, and then have the probe on it, grab it with the surgical instrument. So that way you then can kind of keep hold of it and not lose it again. But I don't scan after the excision is done, mostly because everything is a mess at that time. If anybody listening does or has been to endometriosis surgery, honestly, it's so hard to describe. It's not like there's beautiful surfaces and you can really appreciate that you might have missed a nodule. Everything is a complete mess. Every surface you've opened is bloody. I mean, not actively bleeding, but red from bleeding events or charred from the energy. So it's not really, I think, at least at this point in time, all that viable to check to say, hey, did I catch everything? Did I make sure I found everything? Because it's just, how do you interpret that scan? Everything will look weird. But where I do use it all the time is abdominal wall endometriosis.
Okay, but abdominal wall endometriosis. In France, we now most of the time try to perform cryoablation.
Yeah.
And we tend to perform less and less disease excision for abdominal wall endometriosis because it is a little bit morbid when you consider the gesture sometimes and the large nodules. But I don't know what do you do in Canada so far?
Cryoablation is definitely not happening. I can tell you that. And it's not, from my perspective, at least, because I think it's not useful or there's no place for it. It's really that we have not had, I'd say, innovation in certain domains of gynecology. There's probably weaknesses in the interdisciplinary approach as well, where this historically is done, at least I can say in Canada, done by interventional radiologists and not by gynecologists. Are you doing the cryoablation
No, we refer them to radiologists, interventional radiologists. But we work very closely with them. So basically, it's we follow the patients together, and the gynecologist sees the patients initially. Then the patient meets the interventional radiologist, and the gynecologist meets again the patient for the following follow up at the follow up visit.
Yeah, it's a really cool idea, and I actually have a patient that I saw just a few days ago who has quite a large nodule, and it's like 4 centimeters. So starting to get into the concern of if you take it out, you're going to need a mesh, because if it's invading the muscle, which is this particular case. So, maybe it is less morbid for this patient to try and cryoablate it. And I'll try and refer to our interventional radiologist to see if they'll entertain it. I'll let you know if they will.
Frankly, the patients are very happy with this solution because it's presumed surgery. They can do the procedure on a daily basis. They go home and they quickly see the benefit on the pain symptoms. So I tend to do this most of the time now, except in cases where the nodule is too close from the skin, where you cannot provide with this technique. But I try to do this now most of the time. And I have another question for you. It's about the innovations in ultrasound. Since you started this topic, what are, if you had to plan like the next 5 or 10 years in innovating in ultrasound, how do you see it? And how do you see, since we talk a lot about artificial intelligence, how do you feel this is going to impact your practice of ultrasound?
Very good questions. I'll start with the AI question first, because I'm very involved with Imagendo. This is an interdisciplinary collaborative team out of Adelaide, but it is international now. And essentially, we've been working for a number of years on machine learning in the performance and interpretation of both ultrasound and MRI for endometriosis, and even to a degree, the fusion of ultrasound and MRI, whereby the modalities could enhance the machine learning's capacity to be accurate in a diagnosis by using the adjunct imaging tool. So I do believe very firmly that we're going to be in a space within a few years that will have tools that might help us with the performance. And these are things like annotations or pop-ups telling us about the quality of a picture that we're working on. And then as well, in the interpretation aspect, how this pertains to teams that are in centers of expertise like mine, I think it'll be very interesting to explore, because we're already doing it all and we're doing it effectively. Does it help create efficiency? Hopefully, that would be the main thing. But what could be very interesting is how this is integrated into centers that are not yet doing it, to either help them start doing it, to make it easier for them to learn. I think that's where the innovation is going to lie, because that's where the market need is. It's not so much my hands that need to be better. It's the hands of all of the radiologists and the gynecologists that are doing scanning, but not endometriosis scanning. So I think that's going to be a huge area for innovation. I think what we're also seeing around the world is the movement to understand the superficial endometriosis subtype of the disease from a diagnostic standpoint. So, for example, right now, the IDEA group is putting together a consensus on superficial endometriosis. And we're very, very much at the infancy of this from a research standpoint. Our publication in 2020 was the first ever that said you could find endometriosis directly. You could see it directly on ultrasound. People prior to us tried to find soft markers or indirect features of it, but with mixed results. So we're still at the very, very beginnings of this. our team at McMaster is exploring an ultrasound guided procedure called coldocentesis. This is something that used to be done 1 million years ago, not actually 1 million, but maybe 30 years ago, to diagnose things like ectopic pregnancy by pulling blood out of the cul-de-sac, coldocentesis. And instead, we're pulling out fluid, and we're exploring the combination of ultrasound features of endometriosis and biomarkers. Biomarkers meaning tests that can be sent to a lab that tell us levels of certain molecules. Usually we're looking at inflammatory molecules to understand the presence or absence of the disease. But what I'm most intrigued by is not presence or absence, because I think a lot of the times the imaging gives us that information, is the disease activity. How inflamed is this pelvic cavity? How much inflammatory markers are circulating here? What impact does this have on the patient's pain? What impact does this have on their fertility? We can only see what we can see, but there's all of this stuff that's happening there that we don't understand because it's non-visual. And, the best way for us to think of this is we all know the endometriosis patient who comes in after infertility and they have no dysmenorrhea, they don't complain of any pain symptoms, and they have very bad endometriosis. And you think, why? Why in this patient is the disease this bad, but they're not having pain? Or even people without infertility. I've scanned people who are in their postmenopausal years and they have terrible endo, and you ask them, how are your periods? How was your life? Oh, fine, no problems. So Why? We don't know. What's the invisible force here that's driving people's pain experience? Is it an inflammation marker that can give us some answers? We don't know. But I think there's going to be a lot of innovation in that space as well.
Very interesting. Very interesting, because I think a lot of people are expecting from artificial intelligence, but basically the main issue remains the same. It's how you train people to get sensitive to the diagnostic and get the basic training. So you can implement artificial intelligence to guide the clinicians, the sonographers to detect the disease. But as long as you don't train people to do it, you will not solve the issue. The main issue is to get more people trained to be especially sensitive to diagnose the disease. I think that's the main issue for this disease, basically, because even if you're not talking about ultrasound, but just for dysmenorrhea or other symptoms, most of the times the patient have to visit several practitioners prior just having one to evoke the diagnostic and start the diagnostic procedure and the diagnostic imaging. But that's the main issue for me. And maybe you're right when you say that artificial intelligence can help in this direction. But I think it's going to take years to change. And maybe the new generation can be more active to help the education spread around the practitioners.
It's going to require a team effort. It has to be patients, it has to be gynecologists, it has to be sonographers. Everybody has to come to the table to bring things forward. And I think we're seeing that. I think we're really seeing the unification of the various players in the healthcare team and the patients starting to come together to say, this is important. We need to focus our efforts on this because we haven't. And we've seen the consequence of that, which is dismissal, invalidation, delayed diagnosis, abandoned, incomplete surgeries. We've seen people not get better from this terrible disease. Why? It's not been done right. We have not been managing endometriosis correctly. And I'm not saying what we do is correct, because honestly, in 5 years, in 10 years, I'm sure I'm going to have a slightly different tune to what I'm saying. Everything constantly changes, but we know that what was done was not working, because we know the story of the endometriosis patient, which is constant suffering.
Thank you very much, Dr. Leonardi, for
accepting again our invitation to be involved in our podcast. We hope that our listeners learned more about the ultrasound and its specific role and performances in endometriosis. And we look forward for our next episode. We will have the great honor of receiving Professor Ceccaroni from Italy to discuss about surgery in colorectal endometriosis.
Endotalks podcast, a podcast about the latest research on endometriosis.